Please note today's overview is the first in a series of webinars highlighting components of SHARE and its benefits. At this time, we would like to thank the Arkansas Foundation for Medical Care and HIT Arkansas for their collaboration. To begin, I would like to introduce our presenters. To kick off the presentation, we have Ray Scott, Arkansas Health IT Coordinator, followed by Shirley Tyson, Chief Operations and Technical Officer. And to close, we will hear from Dean Ulmer, the Technical Manager. At this time, Ray Scott.
Thank you, Shauna. Thank everybody for taking time to join us today. We are excited to be here to share with you the developments that are taking place in the launch of the statewide health information exchange for the state. It's an exciting time in our state with a lot of change occurring in the healthcare marketplace and in the healthcare delivery system, and the use of and movement of health information plays a very large role in all of that change. In the state of Arkansas, the HIE, the Health Information Exchange, goes by the name of SHARE, which stands for the State Health Alliance for Records Exchange. The main purpose of SHARE is to enable the movement of critical health information between currently unaffiliated or unconnected healthcare and medical professionals to be used in a way that it actually better informs the delivery of patient care. Jan, could you, remote's not working. Just to give you a quick overview of the path that we have taken to arrive at where we are in our current implementation of SHARE. This graphic simply shows the timeline of the activities and efforts that have gone forth by a very large number of people in this state who participated in a number of workshops, task forces, public meetings, all designed to help plot the vision of what health information exchange in Arkansas could look like. Again, this process started back in the summer of 2009, and it's a real tribute to the participatory process that we used and the involvement and expertise in, again, literally hundreds of individuals who were a part of this process. So a number of people often ask, why do we need to move health information from one point to another when we seem to be doing fine with the information captured at the points of care where it is delivered? For those of us that have either ever personally tried to navigate across a number of different healthcare organizations and or providers, or assisted a relative or a family member in doing so, we know that while each of the individual providers we see and receive care from certainly do an excellent job of collecting and using information about the care that was provided in their particular location, given their particular area of expertise or specialty. Where the problem comes in is when we have to leave that care location or that site of care and then go to another location for other types of health care. And the basic problem, quite frankly, is our information doesn't follow us. And so what that results in is, as this graphic depicts, is that we have what are generally referred to as silos of information or siloed care, where, again, as long as you stay within a particular care system, stay within a particular provider's area, or, frankly, get all of your care at one location, that's not a problem. But as the population in our state continues to age, And as many of us need care and treatment from more than one provider, it really becomes important that the next care provider that you see has access to information that informs them in a very accurate and effective way what other care you received. Right now, we, the patient, are kind of the institutional memory, if you will. We're the only person that generally knows, and sometimes we don't know all of the details or enough of the details, but right now we're the only kind of common connector, if you will, or the common denominator between all of these points of care. So again, what Health Information Exchange is designed to do is to break down these silos of care and provide a way in which the various points of care can actually be connected in a HIPAA-compliant and secure environment that, again, uses this information in what, at the Office of the National Coordinator and in the high-tech legislation that was passed by the U.S. Congress, refers to as meaningful use. Simply put, that means that at these various points of care, that there is a mechanism by which information can be moved and shared in a way that it is used in a meaningful way. And the primary way in which it's used meaningfully is in a way that it actually better informs the care process and care decisions. So again, we are excited to be here today to share with you the progress that we have made. We are in the very early phases of an exciting opportunity in our state to improve the way that we use information to improve health care and eventually improve health care outcomes. So again, thank you for joining us today. At this time, I would like to ask Shirley Tyson to talk with us in more detail and present to you the kinds of activities we are involved in phase one of SHARE. Shirley?
In order to ensure that we have the most comprehensive and useful utility as possible for SHARE, we have decided to deploy the system in a phased approach. So, by beginning with phase one and having basic services available that will enable providers and health service systems to communicate, and starting out with the ability to exchange structured lab results and clinical care summaries, we're launching phase one, which will utilize secure messaging. During phase one, the secure messaging will be utilizing direct standards, and I will go into what those direct standards are shortly. And we'll also have the development of a provider index, and this allows us to uniquely identify not patients, but providers of care for those patients. It is important that the correct information is going to the correct provider as information is being shared. So in order to ensure that this happens, we're developing a unique provider index during phase one. Now, phase two would be a more expanded service. It'll be a more fully scoped and scaled health information exchange, which will include a unique person identifier as well, where patients will be uniquely identified, as well as their sources of care. But that's for later phases down the line. So phase two and beyond will provide much more functionality and serve as a greater utility for health services providers and health service institutions. During phase one, this schematic basically draws out the process of exchanging a secure message. A sender or provider will log in to SHARE. This SHARE will authenticate the user because we are, during our process, identifying the users and providing secure login information, usernames and passwords. Each user will be able to log into SHARE, push a message out to another provider, and SHARE will serve as the health information service provider. So this system will allow all information to be encrypted within SHARE. Nothing will happen outside of the confines of SHARE, which will serve as what is called a HIS. It will identify the receiver, so the provider index will be utilized during this point. It will apply all security protocols as well as push the information out to the receiver. the receiver will have to log into Share in order to access their information. They will be able to receive the message and reply back to the source of the original message, as well as attach information such as a continuity of care document or CCD, or clinical summary, a referral request, a referral approval. All of this information can be shared between the sender and the receiver as long as they are inside the secure space, which would be Share. Share will serve as a facilitation mechanism. We will not house any information within Share. We will serve as the highway to pass the message across from one end to the other. And it is fully a push technology. It is not, you will not have the ability to go in and retrieve information unless something was sent to you directly. The direct standards that would be utilized is a security protocol, which is encouraging the use of standards, which in healthcare you'll know that there's a lot of data that is provided, or PHI, personal health information, that is provided. A lot of this information is not structured. So at one provider's office, it means something very different at the next provider's office. Direct protocol is encouraging the use of standards that is simple, secure, scalable, and standards-based. And this gets us a step closer to having normalized data. So the health information that one provider sends to another will mean the same thing once the receiver receives that information. So direct is a set of protocols or standards that will be utilized in order to ensure that Share is sending along information that is useful. What is secure messaging? Secure messaging is a secure email which allows information to be exchanged from one point to another. Share is an encapsulated system where security protocols are on both ends. There are requirements for both the receiver and the sender of the information. All decryption and encryption happens within the secure space, so nothing is taking place outside of Share. And this allows for the HIPAA compliance that is very crucial in all healthcare settings. So we're trying to ensure that all the required security protocols are being utilized within Share, and the onus is not on the end users to provide that level of security. This could be a huge challenge in healthcare systems, so we're trying to alleviate that challenge. Now, what can be shared through Share? Structured lab results. A structured lab result is information that's produced within the lab that has standards addressed within those results. HL7, LOINC, those are standards that the information can be transported through a secure messaging protocol such as Share in order to go from the source to an end user. There is no translation happening with the structured information. So the information has to be in the appropriate formats that are required. Clinical summary. EHR systems, EMR systems, electronic health or medical record systems, have the ability to create clinical summaries regarding patients. This is important in hospital settings, in emergency rooms, provider offices, especially if referrals are taking place from one provider to another. This information can be attached to a secure message and transmitted through Share from one user to another. The continuity of care documents, or CCDs. There are various types of CCDs based on specialties of care. What other CCD your system can create and produce, it can be attached to a secure message and transmitted from one provider to another. Referrals. This is important because a lot of times faxing or transporting referrals through patients is an inefficient way of getting information to providers. By attaching your referral to an electronic message, you're able to ensure that the referral goes to the end user in advance of the patient. Also, clinical summaries or information can be sent along with those referrals. The secure messaging also accepts unstructured data or unstructured documents, such as a Word document, a PDF, or a JPEG. Any of this information can be attached to a secure message and open at the end user. So the secure messaging functionality is pretty broad, and it will allow for the ability to exchange information just like a traditional email system, but with that extra layer of security that allows for the encryption and decryption to take place within a secure space. During phase one, the secure messaging adds quite a few benefits. Now, this is very basic technology at this point. The advanced components are around the security and the standards. So this won't look as if you're getting a lot of expanded functionality, but the importance of this phase is around the security protocols that will be available. Because we are starting out with phase one in secure messaging, everything is going to be internet-based. You will not need any external application. You will be logging into a system. If you have internet access, you will be able to access Share through phase one. You will also not have to load any software or buy any special hardware to access Share during phase one. Phase one is, again, HIPAA and high-tech compliance. We have developed privacy and security standards that will be addressed during phase one and future phases. We may be starting out simple, but we want to set up our system so that as we expand, we have fully protected all the information and allow for all the privacy and security standards. We have promulgated privacy rules, and that information can be found on our website as well, and that is ohit.org. ohit.arkansas.gov. So again, at the end of the presentation, you will see our website information. You will also be able to utilize phase one using mobile devices, so iPhones, BlackBerries, iPads. If you have the ability to email, you will be able to access this information and utilize phase one of Share through your mobile devices. You can connect from anywhere at any time, and the security is still in place. The additional component to phase one is the provider directory. Again, it is very important that we uniquely identify the providers. Where problems will occur is information about patients are sent to the wrong locations. If a provider is not signed up for Share, they will not be able to receive any information about a patient. So it's important that providers sign up for Share so that we can collect the information that identifies those providers uniquely. And we have put in a process of identity proofing that will ensure that we are able to uniquely identify each provider within our provider directory. There are very different processes that are going on around the provider directory and the validation and reconciliation of each provider. All of this will take place during our onboarding phase of Share. Onboarding into Share is a tiered process, and Dean Ulmer will take it from here to discuss what exactly takes place during the onboarding. Dean?
Thank you, Shirley. As you'll see by this map, in order to roll out secure messaging to the entire state, we divided the state into 8 regions. Those regions will be covered by our implementation specialists that will be working with the healthcare providers in each of those regions. Currently, we're focusing on regions 1, 2, and 5. You'll notice the schedule at the bottom. Those will be the regions in the order that they'll fall. In addition, we understand that healthcare providers provide care across region lines. So in order to provide services to cover those communities of care, we cross region lines and cover surrounding areas. For example, medical centers with outlying clinics and offices in other regions, we will cover those as well. Also, our community health centers that are located in the state of Arkansas, which have over 70 locations. We are working to connect them together in order to give them the most use out of the system. Again, we have our implementation specialists will be traveling to each one of these regions, and we'll be working in each one of these areas to get these facilities connected to our secure messaging email. During onboarding, our specialists will be coming to each of the facilities and discussing the different phases of the process. We initially will begin with an orientation meeting. During this meeting, we will provide educational material on secure messaging and also determine the interest in secure messaging as well as the expansion to the full functioning HIE. Following that, we will define our project team, which will involve OHI team members as well as staff in the facility. We will do a workflow analysis to help understand the facility's workflow and how secure messaging fits into that workflow and can help improve it. We will work to sign participation agreements, to define and agree on the uses and access to share. The project team will also assist in collecting user IDs and assigning passwords. For some larger locations, we will designate a facility contact to help us coordinate this process. Following this, we'll have training. This will be scheduled to help initial users sign on. They will be given their IDs and passwords and will be required to test and send messages to make sure that everything is functioning properly. 2 weeks following the training, we will come back and do a post-implementation survey in which we will help resolve any issues that may be remaining. This chart shows our current progress with secure messaging in the state. As you can see, it shows all the providers that we're working with currently to be connected through secure messaging. We have 168 accounts or providers that we're working with at the moment. And as you can see by the bottom, the regions are not just covered by 1, 2, and 5. We're covered additional regions to span across the whole state. This initial deployment of phase 1 of secure messaging is at no cost to the participants, but we will be convening stakeholder meetings to review the payment structure for the future. Shauna, I'll turn it back over to you.
Thank you, Dean. You have heard about share in phase 1 and what will be entailed, and as well as our rollout process. To learn more about opportunities for onboarding, we encourage you to visit our website at www.ohit.arkansas.gov to learn more about our onboarding opportunities. To unmute the phone lines to allow for question and answer if you don't want to ask me. And I wanted to ask that everyone mute your individual phone lines as we are recording today's webinar, and that will keep background noise to a minimum.
While we're doing that, looks like we have one question that came into the chat line.
Can meet that meaningful use requirement. There's some to facilitate, but the health department has phases of share will be able to address the final rules around meaningful use stage 2. Because those final rules stage 2 requirements, we will not be able to address those until the final rule has been released.
Thank you.
Also, if you'd like to email your questions in to us, you can send email. Currently, everybody that the lines are open now, if you've got background noise, other activity going within the community, and but we are currently assessing what those needs are and how share regions be carried out. Will the exchange of medical images be supported in phase 1? There is a size limit on the attachment for phase 1, and I believe that size limit is 10 meg files. If your files can be compressed to less than 10 megs, you can exchange that information during phase an issue. But if you can compress your file, phase 1 is in as phase 2 comes into play. So we will not stop onboarding providers as providers want to be onboarded to phase 1.
Okay. Next question we have is share the only option for this kind of service in Arkansas?
This time, yes, it is. There are integrated delivery networks, large hospital systems, large clinicians. What we don't have is healthcare entities and organizations. Our understanding is that and not occurring through a secure interface and connection, which then, frankly, puts that information at risk in terms of, again, not having it occur in a secure environment.
Message would be encrypted, so none of that information would be utilized during phase 1. We will not be able to go in and extract any information. So the unique ID that's within the HR.
Okay. Next question is kind of in the same vein.
OHIP will not centrally house any of that information. They all information share.
Next question is, will share ever become mandatory so that all providers will have to adopt it?
Share is really I like to think it's the meaningful use staging process, a la Medicaid or Medicare. I think as you look at the legislation and regulations and policy around movement towards accountable, unnecessary readmission is going to become mandatory. And I think if you services delivered in and of itself is probably not going to be the way healthcare is going to be either purchased or reimbursed in the future. Quality indicators, not just reimbursement on the basis of what procedure was done, but actually those are the kinds of things that actually are going to drive the increase. Share is not. Again, I would ask you to think of it as a utility, much like your electric company that provides a mechanism in a secure environment to move protected, secure health information, referred to as an EMR Lite, an electronic medical record that's a web-based application that a provider could access and use. It meets all of the current HIT standards promulgated by the Office of the National Coordinator. That product will, in fact, qualify folks to achieve meaningful use and, therefore, to receive the electronic health record incentive payments from either Medicaid or Medicare. That option and that opportunity is on our drawing board. It is a part of the longer-term vision for share. I'm not certain at this point when we assume that option will be available, but probably later in this calendar year.
Next question we have is, will the hospital need to enter into a business associate agreement with share to meet MU guidelines on third-party information sharing?
We would, it actually is based on how each hospital plans to utilize share. Participation agreements will be a requirement regardless. A business associate agreement will only be required if the hospital or large clinic or facility wants to utilize share in a way that will make that requirement a necessity. Each hospital has different rules around that. If they want to use share to send for third-party use, then they will definitely have to have a business associate agreement. We have drafted business associate agreements for each of the environments we plan to deploy share, just in case this is something that each of those end users want to utilize share to do. So participation agreements are mandatory. Business associate agreements are available depending on how each of the entities want to utilize share.
Okay. This is another technical question. It says, for the submission of lab results and clinical summaries, are we expected to export files in a structured format from our EHR system?
That depends on what you want to do. If you want to send a structured message, which is in an HL7 or LOINC,
depending on what your system is capable of creating, then you will have to export that externally to your LIMS system and then attach it to the secure email message. So you will have to create the message, the attachment, in order to send it along with the message.
Next question, again, has to do with timelines. It says, do you expect phase 1 and phase 2 to overlap?
Yes. Again, phase 2 is a continuation of phase 1 with expanded services.
This says, so the success of SHARE program and its benefits for providers are dependent upon the level of participation by healthcare providers. What level of participation are you expecting?
We really expect a very high level of participation. We've gotten a great response. So far, we only started deploying phase 1 a few weeks ago, and we already have a good number of providers onboarded with a list of those waiting to be. So we expect a good penetration. Also, the reason we decided to take a regional approach is to increase the functionality of SHARE and the usefulness. Providers will treat patients within their regions. And if there's not enough information around patients in your region, then SHARE would not be useful. So we're trying to make SHARE as useful a utility as possible. And we do know there's a great deal of interest in SHARE in the provider community today. And our providers are not isolated to physician providers. There are also ancillary care providers that want to share information about patients as well. So again, SHARE is trying to be as comprehensive as possible and provide services to as broad a base of providers or health services providers as possible.
All right, the next question, looks like we have time for a few more. So the next question is, will this be nationwide or strictly within the state of Arkansas?
The vision of the HITECH Act, which was passed by the Congress actually a number of years ago, this whole health information technology initiative actually started in the last 2 years of the Bush administration. The vision, as was articulated at that point, was that what this country needs in order to better coordinate healthcare is a nationwide health information exchange infrastructure. So one of the questions we often get, well, is if that was the policy, the national policy, why didn't the federal government just give all of the states a mandate, tell them this is the model, and let the states go to work? And the most obvious answer to that question is because every state is at a very different stage of evolution and development pursuant to the previous question. You know, the current rate of adoption and use of electronic health record technology varies widely from one state to the next. So literally there was no way to tell every state in this nation that they had to start at the same point, because every state in the nation is not at the same point. So the ultimate objective, though, is to have all of these state health information exchanges have the capacity and the ability to exchange data across an interstate network. I would ask you also to keep in mind that we have a large number of border cities in the state where folks may live in Arkansas, but they may go to Louisiana, Oklahoma, Mississippi, or Louisiana, or Texas for their health care. So again, we have that need to have that interstate capability, and that's a part of the design and vision for SHARE. So we actually have that need currently, but envision a situation where perhaps you're on vacation with your family in California, and you're involved in a terrible auto accident, and you wind up in the emergency department, and there's no way of them knowing what kind of meds you're on. There's no way of them finding out what your current health status or health conditions are. Part of the advantage of having this nationwide network is for the healthcare providers in California to actually be able to access your healthcare information in Arkansas. And if it's 2 a.m. and they can't get a hold of the doctor's exchange or can't find your physician, it can, in fact, be a life-saving moment.
All right. Next question we have here is, will a provider be able to perform a blind search for available patient information, or will the provider need to know where a patient has received previous care in order to obtain that information?
If a provider has unique identifying information that will be defined, they will be able to access the patient's information and do a search on the patient without knowing the source of their care. The way our system is set up is that we will be able to uniquely identify the patients and also connect them to their sources of care. So you can go in, you will have two options to be able to access that patient's information, whether you have the most recent location of care or if you just have the unique information about the patient.
All right. Another one here. Can any of the information submitted to SHARE be shared with other state-level agencies, for example, syndromic surveillance info, reportable lab, QMS measures?
Actually, that is possible. We will have to have a business associate agreement with those entities because of the level of information that will be shared. And we have been collaborating with other state entities, public health, Department of Human Services, in order to ensure that SHARE has some level of functionality for their facilities as well. So yes, that is a possibility. But a business associate agreement would have to be in place as well.
Okay, maybe the last question that we take, and if you have any further questions, you can certainly submit those. The information is up there on the screen. So the last we have is, with most secure messaging, there's a time limit on when the secure message can be pulled up. How long will a provider have access to the secure information that was sent?
Right now, we have not put in the clock. We want to assess the needs of our provider community before we impose a timeline on how long the messages will be available within that secure space for each of those providers. So part of Dean's onboarding process is that follow-up. And part of the follow-up is to determine how useful the secure messaging has been for them, as well as determining what type of parameters we would like to put in place in order to set those timelines. We would like to ensure that the system is as useful to those providers as possible before we start imposing some timelines on the system. But that information will be communicated to every user once those timelines have been established.
Thank you all for your participation in today's webinar, as well as for your plentiful questions. We appreciate that. If you have further information or need further information, we encourage you to email or call us at the numbers listed on your screen, or to also send us information through our website. Again, the website is noted at www.ohit.arkansas.gov. Thank you.